Good afternoon, everyone. It's certainly a pleasure and an honor to be here, and it's really nice to be on the other side of the question, so I'm going to enjoy this. So, Rhonda, you served as AONE president in 1993 to 94, and as a member of the board prior to that. What were the top 3 highlights during your time serving in AONE leadership?
I would have to say that one of the top 3 was around the expansion of the membership of AONE. First, if you remember, the organization started as the American Society of Nursing Service Administrators. And I had the privilege of being a student with Dorothy Johnson, who conceived the idea and actually convinced John Danielson, who was president or chairman of the board of AHA. They worked together at Evanston Hospital in Illinois, and she felt it was important for it not just to be a council, but to have much more of an integrated role within AHA. So she convinced him that this organization would evolve from that council to the American Society of Nursing Service Administrators. Actually, there was an H in there, Hospital Nursing Service Administrators. They then removed that. It was only for nurse executives. And they removed the H, and they expanded just a little bit, not very much, over the years. But during my board's time, and the board was absolutely phenomenal, we had the Council of Nurse Managers, and the board really identified the fact that expansion, inclusivity of leaders of all levels and all areas, meaning on the continuum, in education, et cetera, was really important. And so that evolved during that time, and that was one top highlight. And I just want to thank, there are many individuals here today who were on that board and or involved in that decision because it was a membership vote. And I want to thank all of you, because if you look around, look at the richness. Look at the richness of this organization and the wisdom of everybody, not only in this room, but out there at all the other sessions and all the presenters. So it was a real milestone within this organization. The second thing was our partnerships. And I talk about our partnerships in relationship to public policy. We not only worked with the AHA during that time, but the Tri-Council. And I will just have to say that one of the highlights of my personal career was being in the presidency at this time, because all of us that were in these roles on the Tri-Council were part of Hillary Clinton's task force on healthcare reform when President Bill Clinton was in office. It was probably one of the most rewarding experiences, not only to hear the direction that they were trying to take healthcare, but to be a part of creating what that new healthcare reform was going to look like. Unfortunately, I think she was before her time as a first lady, because first ladies didn't lead those kinds of things generally back then. And of course, we didn't have a change. But it was one of the highlights, and it positioned AONE in a totally different light in public policy at that time. It really thrust us forward. And then the third was our international work. We had the experience of being able to go to and be present at the International Congress of Nursing. It was the first time we were in Spain, and it was the first time that we were involved in international work with this organization. So I would say, Maureen, those are the 3 highlights. There are a lot more. I do want to add one little thing, and it is about the partnerships. It's not public policy, but partnerships. The chairman of ACHE at the time was a gentleman that I worked with personally years before that. His name was Ron Spaeth. And as you probably remember, or many of you might remember, ACHE didn't have very many nurses in it. And I said to Ron, you've got a huge mistake. We really need to have an invite that includes nurses. You can't do your work without nurses. And so I think that was the launching of both a partnership between ACHE and AONE, but really having nursing in a different space that is outside of the, if you will, the nursing organizations. So those partnerships are absolutely key.
Great. Thank you, Rhonda. Now to Pam. In 2010, AONE developed its current mission statement to shape healthcare through innovative and expert nursing leadership and vision, global nursing leadership, one voice, advancing health. Pam, can you explain this change and the role AONE's international work played into this?
Yes, thank you, Maureen. The strategic plan for AONE each year looked at the mission and vision, and in 2000 we made a decision not to change it. Our history before had been every year we tweaked it a little bit, and in 2000 we decided we would leave it and see if it was going to be appropriate enough for us to move forward with our strategies. We revisited it every year, and we looked at it at the beginning of our strategic planning and reaffirmed it was still the right mission and vision. But then in 2010, we looked at it and it just didn't fit anymore. And one of the reasons why is that we had really expanded the work that we were doing, and we came to this really interesting realization that our vision had actually become our mission, and we had accomplished our vision, which feedback that we got from other associations was that was highly unusual, and they attributed it to the fact that we stayed so true to that. So when we had our new mission, we had to come up with our new vision. But the other thing that had happened during that time was our expanse beyond the United States to really exploring how we could be a member of the global community. We were participating, as Rhonda said, in the ICN meetings. We were submitting abstracts every year. They were being accepted every other year. That's when they meet. And the feedback we were getting is that our competencies and our guiding principles were being adapted worldwide. And people were coming up to us at subsequent ICN meetings to say, we're using your competencies to develop our graduate program. We're using your competencies in a multitude of ways. I also learned that there's no international trademark. So they very graciously lifted them for whatever purposes that they wanted. And we were thrilled, because what it meant was that AONE's approach to leadership was one that was actually going to take hold internationally, and we were very proud of that, and we wanted to reflect that for our own members. We were also participating in People to People every 2 years and taking delegates from the United States to countries. That originally had started with Carol Bradley and a trip to Cuba, and then we became partners with People to People so that we began to go every 2 years. We would take a delegation of American nurses, and we would meet with our counterparts in other countries. And we went to places like Russia, China, India, South Africa, Costa Rica, and recently Israel. But at the time, it was the beginning of those relationships. And again, when we would meet with our counterparts, we would find that we had much more in common in leadership and much more in common in taking care of patients, because that's our universal language, is caring for patients and families. And again, we were engaged in an international conversation about that. We were also continuing a partnership that I had started when I was previously at Dartmouth with the Croatian Nurses Association, and we were working with them every 2 years to do a congress, an international congress in Eastern Europe. And that was another place where our voice was being heard, and we were working with nurses in that. So it became a part of our fabric of where we were seeing our influence, and it seemed only to make sense to change and actually create our vision with that scope in mind, that the global was really a part of what we were going to do. I think it's fair to say AONE now is a member of the global community. We are participating continuing to participate at the global, and I'm really excited because the Croatian Nursing Conference that we're doing this year, we're actually partnering with the European Nursing Directors Association, which means attendance will be all of Europe. And the 3 groups will be sponsoring it, so that's how we got there.
That's great. Thank you, Pam. And I will say, personally and professionally, having been one of the leads on the Israel trip. It was just one of the most amazing, and hopefully you got to read, we put a little bit of an article in The Voice on that trip, and I know I've connected with some of my colleagues that traveled with us, and it was just an incredible experience and what we learned from the nurses in Israel. So you started as AONE CEO in 2000 and transitioned into the CEO Emeritus role last summer. During your tenure, AONE transitioned from only hosting an annual meeting to developing a number of programs to meet our members' needs. From the nurse executives to nurse managers, why did AONE move into this direction, and what were the first education programs to be developed?
As you said, we moved in that direction to meet our member needs. We felt that the annual meeting was a wonderful opportunity to bring people together with experts and speakers from around the world, but we had, and around the country, but we also had specific needs within the different aspects of our membership. One of the things that drove our early development was a sense that we had no succession plan for leadership in the United States, and we felt that AONE could be a leader in that. So we began to focus on what we called aspiring nurse leaders, people that were early on into their decision that leadership would be their track. And we developed programs for nurses that were charge nurses, beginning nurse managers. That evolved into the nurse manager institutes, the earlier institutes that began to focus on what is it you would love about management. And we had plenty of people to tell us what they didn't like about management, but there weren't a lot of people out there talking about why is this an exciting field and why do you want to do this? And so we started trying to focus on that to get people more and more interested, and those began to evolve into our premier programs, which are the Nursing Manager Fellowship and the Nursing Director Fellowship. And I think that he's going to talk about the future, but that's going to be where we continue to move to the nurse executives. Remembering at the time, the nurse executives had the Wharton program and they had the Robert Wood Johnson Nurse Executive Program. So there was a field need met with those two outstanding programs, but those have since closed. And so the need to really move back into the nursing executive arena is going to be critical. But I think if you look back on where we focused on nurse executives during that time, it was around the competencies around finance and working with HFMA. I had a wonderful relation with their previous CEO, Dick Clark, who I had long conversations with. Why is it that you think nurses don't have good financial skills? I've looked at what the what hospital administrators get in finance, and it's not that many courses. And we need to figure out how to make that just as clear a skill set of nurse executives. They run businesses. So that early work culminated recently in the healthcare finance course that we do with HFMA. But we started out by looking at where are the needs of our members and how do we meet those. And even things like working with Eugene Litvak in the Optimization Center in Boston was a way of getting us involved with outside thinking, and not just around the nursing, but looking at different ways of applying different sciences to our work.
Great, thank you. Rhonda mentioned AONE's work with the Tri-Council for Nursing, but AONE also has partnered with a number of individual organizations, as you mentioned, HFMA, to develop joint statements and guiding principles. Mm-hmm. Can you talk about some of those partnerships and the result and impact it had on the nursing profession and healthcare delivery?
Yes. When I was getting ready for this, I've forgotten how many people we have worked with. And it's really been exciting to look back on that over the years. The board came from a perspective that we weren't going to do any of the work alone. We were going to need to partner. We were going to need to reach out with people. And one of the first things we started developing were the guiding principles. And the way in which we would do those is meet with experts in a field of content and then come up with guiding principles to lead nurse leaders. So some of the people we partnered with were the Hartford Institute on the care of elderly in the workplace, keeping in mind that we don't usually do clinical work, but the care of the elderly represents over 50% of the patients that we care for today. So we felt that it was an important partnership to have. We worked with the architects on designing hospitals of the future and how to make sure patient care concepts got integrated correctly. We worked with Hill-Rom on a number of guiding principles around the use of IT and how it's linked to clinical outcome. And one of the exciting ones was we worked with them on a second set of work on how nurse executives, CIOs, and the tech companies can work better together. We worked with Aramark to look at how do we work better with our ancillary departments, and we created an actual research-based survey on satisfaction to make sure that that very important part of our nursing delivery system was integrated into the work that we do. And most recently, we worked with the Emergency Nurses Association to develop the guidelines for mitigating violence in the workplace. Each of them aimed at what's the role of nursing in here, and what is the role of the nurse leader, and what is it that we can offer as guidelines to our members to do that. We had some other major projects that we did around our competencies, and also with AAC and critical care and AORN around the nurse manager competencies. That was developed in a partnership as well. Our path of having worked successfully in partnerships, I think, is well established now, and it's some of the exciting work that I think we get to do.
That's great. Thank you, Pam. So Cole, Pam talked about AONE's mission, key relationships, and a role as convener, partner, and synthesizer. Cole, as a panelist who currently sits on the board, can you talk about AONE's current strategic priorities and some of the things AONE is doing to address these key priorities?
Yes, thank you. First of all, it's an honor to be here with you all and to be able to be a part of this very distinguished panel. I appreciate the work that has been done and the foundations that have been laid, because if we kind of project ourselves into the future, one, we have a nice visual so you can actually see the future, if you would like. This is a wonderful one-pager kind of visual that we can look at that helps guide us into that. But we do know two things about the future as we start to predict it. One is that you may be a little bit right, but you will absolutely be a lot wrong. So as we think about that with a framework of what we're going to talk about is the future of AONE, which is why we really need a very strong strategic plan that's anchored with our mission, our vision, our values, and to be able to really clearly define who our partners are. I also thought about the idea that what Mike said, which is throw that life preserver way out there and swim to it. And I think we're still developing some of those professional models and competencies that we need to move forward with in the future. So we have a lot of the must-haves on our strategic plan. And those areas really include continuing on the great work that's already been done in defining the competencies of today's nurse leaders, but also looking into the future to see what those competencies may need to be. And some of the projections are that we really need to understand more about population health, our role in population health, how we are going to bring to bear the interprofessional competencies into nursing, how we will continue to lead some of that work, but also find our place among the team, which gives us, some of us, some angst, but also great opportunity that's really been identified. I look at this room and I will just tell you that I see a ton of folks who, what I would call constructive irritants. This is our role as nurse leaders most often, as defined by John Izzo, who talked about as constructive irritants, one of the things we do is we do project ourselves into the future, and we do think about what our strategies need to be and our tactics. And we may come with a problem, but we also come with a solution. And that's a really critical part of the strategic planning process for us and being very tactical in nature. There's also three questions that I think we use to kind of frame our work. And this was actually from a physicist named Javardia, who when talking to students as they're beginning to choose their career paths, they should ask themselves these three questions. And I think we should do that as nurse leaders. One is, does this work bring joy to us? And we have talked a lot about resiliency and joy and gratitude. The second is, does this work serve humanity? And I think I can honestly say absolutely. The work that we're doing as nurses and nurse leaders strategically and tactically absolutely serves humanity. The last question really there is, does this serve the earth? Are we good stewards of this, and are we building for the future? And as we go through our strategic plan and we think a little bit more about this, one of the things that we have to really do is create more healthful and practicing environments. We need to have healthy practice environments for our nurses. We have to realize that workplace violence, incivility, and bullying occur on a continuum, and the fact that the work that's been started here will have to be carried on into the future through other partnerships that we need to have. We have to address the violence not only in our hospitals, but also in our communities. In terms of kind of engaging in cross-continuum work, we're going to have to continue to develop our skills in the post-acute and the pre-acute settings. And we're going to have to develop and diversify our membership and our leadership to really bring those new competencies and skills into AONE. And there are task forces working on that right now to look at what are those competencies and how do we truly diversify our membership. There's always strength in diversity, but that also adds additional challenges to us as well in finding a common path forward and kind of a common language. In terms of working in the future, we're going to have to make sure we have very secure partnerships with people and with other organizations. The foundations have been laid. We have wonderful colleagues. We're now working as well with the AACN to actually develop what looks like an academic practice partnership. And if that sounds like it's back to the future, it probably is. We have been talking about it for a long time. And I think the commitment here is to make it a reality. How do we truly bridge that gap so we no longer talk about that as nurse leaders and practicing nurses and academicians? So those strategic priorities are the things that are really defining us well into the future.
Great, Cole, thank you for that very positive outlook for the future with regard to AONE. So now I'm going to kind of take us to a little bit of our current reality. And so I'm going to open this up to our panel. Considering what's going on in Washington these days with efforts to reform healthcare and decrease funding for education, it's critical nurse leaders are informed about how proposed changes are impacting nursing. What are some of the key issues nurse leaders should know, and what messages should they deliver to their organizations and Congress?
Anybody?
Anybody?
I'll go.
Okay.
I have the privilege of, for AHA, sitting on the Measurement Application Partnership. And the Measurement Application Partnership, since the ACA went into effect, every year has been the organization that recommends to CMS the measures that will be for pay for performance. First it was pay for submission of the data. But when you ask that question, it really makes me think about how do we, as the nurse leaders, share with our organizational colleagues, both our bedside associates as well as our C-suite, how do we share with them the investment that they're making in nursing and its importance, not only to the outcomes of the patient, because as Pam said, that's our common language, but now it's transitioning to the revenue stream. Because if we look at those outcomes, and if we look at the aspects of what's being measured and what's being paid, we're finding that most of those things center around whether our nursing care is excellent or whether we have some difficulties with our nursing care. Judy and BJ did a great job yesterday, I think, talking about return on investment at what I would call the C-suite table. Now we need to take it to another level at the C-suite table, which is making certain that it's truly understood that the revenue stream is impacted by the outcomes of our nursing practice.
Great, thank you, Rhonda. Pam, what do you see AONE's role in addressing some of these issues?
Well, I think the most important is voice and where we put our voices. I made a plea for that yesterday, that we need every voice. I don't care what you say, just say it. And what I mean by that is in your arena, in your field, you need to be talking about what value nursing brings in whatever language is needed. If you're talking to finance, you need to understand that language and speak in that language. If you're talking to quality people where you're more comfortable, you still need to be able to translate. And we can't always talk about it from a nursing perspective. We really have to be multilingual in how we do this, and in every opportunity be able to advocate for the value that nursing brings. But I am going to say that we really need you most in your voice in Washington, in however way you want to interact with that. We need voices in Washington that bring what happens at the bedside with the regulations and the policies that get enacted. And so that there's a connection between that policy and what happens to the constituents in their areas and what happens to the people that vote for them in those specific terms. So I think that nursing's voice is never been more important than it is right now, but it is a very articulated voice, and it needs to be well-focused and well-targeted.
It's great. Thank you, Pam. Anything to add, Cole?
Yeah, I would add, along with the idea of it being focused and having a lot of clarity, is the positioning of nurses in the future. I know that AONE was one of the founding members of the Nurses on Boards Coalition, and the opportunity to be able to try and position 10,000 nurses on influential boards, which to me also means political offices. And I'll just start it now, hashtag a nurse for president, right? I think that would be awesome. Yeah. It's definitely important for us to go to the table, be at the table, be an active voice, and one of the ways that we're going to do that is through this coalition and through our work. But more importantly than the number are the people that get positioned there, having the right folks with the right competencies, the right messages, and being a part of the larger solution. So I do think that that's critically important, is that we get there, we stay there, and we have a seat at the table, because I think someone said if you're not at the table, you're on the menu. So let's not be on the menu.
Thank you. So true, so true. As we look to the future, how does AONE remain relevant as an organization and nursing leadership as a profession?
Oh, you want to start with one of the easy ones, right? Well, I'll jump in. I think that the relevancy will be as good as we stay close to what the members need. And I think one of the roles that AONE serves is to be out there a little bit in front and sort of scanning that horizon in that environment for what's really needed. And that, you know, as an association, we have an obligation to make sure we're doing that while you're doing the hard work of what needs to be done today. And I think that's the partnership of making sure we're out far enough as an organization to see what's coming, and then to inform people so that we can all get ready for where that needs to be. That is the definition of relevancy, is that you're defining who you are based on what people will need, not just today, but in the future. So I think that's a key piece.
So
I also think, as we think about that, sometimes we get stuck in our history. Mm-hmm. And it's important to have that foundation and know, but it isn't important for us to stay stuck. And sometimes when change occurs, and it happens in our own organizations, and if it happens in a national organization like this, there's a lot of disruption. And I think just going back to our history and one of the learnings, when we opened up the membership, there was a lot of disruption and a lot of angst from individuals who had been in the sort of inner circle of the old organization. I just ask all of us to remember that our future isn't me at this age. Our future is you at your age.
Yeah.
thank you. So I'm going to skip through a few of these because I know we won't get to 70-something of them, but I'm intrigued by the innovation because we did have a little bit of that in a speaker that spoke to us yesterday. Why is innovation essential to the future of nursing and healthcare?
Another easy one.
And they're looking at me, so.
We are.
Oh, youngin.
That's right. So I'll start the conversation. I think without innovation, we don't have the survival that we need and the sustainability that we need as an organization. And to reflect on the earlier question, I would have also added the fact that in order for us to remain relevant, we do have to innovate. And we have to be very inclusive about how we do that. And as we move forward, the more voices at the table, the better. We also have to realize that we have a sense of power and privilege as an organization that needs to be extended to other people to be able to lift them up. But innovation really is our future, and disruptive innovation is ultimately about making a product or a service or an idea available to the broader public that can be consumed by the broader public. So if we really want to be relevant, we do have to really think about how innovation is going to become a core skill. You know, Dr. Clark started us out by talking about persistence, and I would add innovation to that list, along with agility, vitality, courage, and to your point, the whole idea of being relevant and resilient.
I would just add a reminder that there's a difference between quality improvement and innovation. And I think sometimes we forget and we hold those together. Quality improvement is improving a current process. Innovation is creating something entirely different. I think our skill set is more in the quality improvement, and we need to really build up our skill set in innovation, because that means blow it up. And we're not that good at blowing up. We do a lot of Band-Aids and putting it together. We have to become comfortable with the idea that blowing it up is the appropriate action to take.
So after we blow it up, what do you think nursing and nursing leadership will look like in 50 years?
Take it away, not cool.
I definitely think it will be more diverse, which I think is a great thing. I see some of the future faces of nurse leaders in here, and that's awesome. They're going to be leading us and taking on the challenges of the future. I think they're going to have a different skill set and a different set of competencies, and we're going to have to be way more comfortable in the interprofessional space. We're going to have to think about our competencies as boundary spanners and really being comfortable moving into that. We're going to have to really get comfortable with technology guiding us and supporting and really elevating our decisions to be better. And one of the ways that I think is coming around in that, and even my generation of nurses, the human genome wasn't mapped when we went to school.
It wasn't defined.
It is now, and that has changed everything. Genetics, genomics, pharmacogenomics, any kind of omics you want to add is now really impacting our lives. We also now have the benefit of things like machine learning that we never had before to make our decisions better. Unfortunately, mathematically, we can map decision-making and oftentimes make better decisions through using mathematical equations as opposed to always the human experience. So we're going to have to get much more comfortable with how technology is going to be integrated into our role as nurse leaders. And telehealth, telemedicine, telenurse, whatever that is, we're going to have to really understand how we're going to be operating in much more of a virtual world as leaders, and certainly a world that doesn't necessarily provide the type of connections that we have today.
I'd really like to underscore that, because I think we talk about technology sort of every once in a while, like we talk about quality, you know. But the technology, even in 2 years from now, is going to be so different. And so how will we relate to our associates? How will we relate to our associates, and how will they relate to us? As we watch our grandchildren talk with each other across the table by texting, how will that affect the way we work with every associate in our organization across the continuum of care? And how will they be relating with their patients or the members that they are caring for in their health system? So I think that will be very, very different, and it's not going to be that gradual evolution. I think we're going to see, even in 5 years from now, an exponential jump in how all of that is. So how are you going to take what Terry talked about today in terms of mindfulness and work with that, with technology, with our associates? That's where I see us in the future.
That's great. So we've also had a change within AONE with regard to moving from chapters to affiliates. So how does AONE work with state affiliates to make nursing leadership stronger from a state to a national level?
Well, I'll kick off. I think that the relationship that we have with our affiliates and at the national level give us some ability to be really targeted and focused when we need to. If you look at AONE as being the national focus, and you look at our state affiliates as a state focus, that's really going to be coming at problems from two different directions, both of which are absolutely essential. And I think keeping that as a strong partnership will only make us stronger across the nation. Even though we may be doing things in individual states, there's a commonality to the goal, and there's a commonality to what we're trying to achieve. And I think that dualness of effort is absolutely critical, but I also think it's a real grounded foundation of what will make us stronger. Because we are 50 states, 50 ways of doing things, 50 ways of going at something, 50 different policies, 50 different laws. And we have somehow managed to keep that as a united 50 states. And I think nursing needs to be able to do that as well. And we've got lots of numbers to do it.
Thank you, great. And this has come up in other topics, and I've had discussions with ACHE about this with regard to nurses who are CEOs. So as more RNs obtain a CEO role, how will AONE use this subset to develop other RNs who aspire to be CEOs? Are there common specialty traits of those RNs who have become a CEO?
Well, I have to get on my platform here first. I've had the privilege of being a CEO. And one of the things that I have as a flag-waving concern is that nurses, when they move into a CEO position, many of them, and I don't have the actual statistic, drop RN. I go around looking at people's badges and saying, their hospital badges, and saying, why isn't there an RN? And you know what was told to me by someone? The job doesn't require it. So I used two examples. First of all was, do you think there's any MD in a CEO position that drops the MD? Probably not, right? But the second one, actually the first one that I talk about, is what we know as a nurse about our basic business, which is patient care, and how important that is to be able to bring to that role. Because everybody learns, as Pam was talking about, the finance, et cetera. But when you look at someone who's gone through an MHA program only, they rarely have any interaction with what our basic product is, which is patient care outcomes. So from my perspective, that's where AONE is really, really a wonderful organization and will be in the future for nurses who are in CEO positions, who will help not only in the connections that we have, but the skill sets and the competencies in that CEO role that are unique to nurses and that should be promulgated throughout this country.
That's great, thank you. Anything?
I just would reiterate that it's part of our relevancy of no matter where you are as a nurse leader, you're a nurse leader.
Absolutely.
And the title, you're going to do hashtag president, and I'll do hashtag head of all hospitals. But
All systems.
all systems, all systems. I think the distinction is that we not get caught up in the title, but we get caught up in what is the expertise we bring to the table. And we bring a lot of expertise in a lot of different arenas, and we're very smart people, and we need to utilize that smartness in the ways that will help us deliver the quality care that we have the ability to do. So no matter what your title, you have an obligation to do that. And I think you see hospitals that are run by CNOs or even physicians that have training in management have a better sense of what their business is. And I think that, but that also, I also know of many CEOs that have an excellent sense of what their business is. So it's as much that of, can we focus on what really matters? We were told to clarify our two values, and I think that was probably one of my takeaways from this week is you got to have two, not three, two, so that you can stay focused. And actually, Phyllis Critic would say you need to be three because a two makes it an either or. Three makes it something you can deal with, but we've got to be there on that one, no matter what role you're in.
That's great, thank you. So many nurse leaders, and I think, Cole, you touched a little bit on this when we talked about the future, but many nurse leaders working across the continuum of care identify with and look to other organizations, such as AHCA, for leader development and advocacy. How can we partner with these organizations to create a more unified voice of leaders across the continuum of care?
Well, I would first start by saying we need to open up a dialogue, and we need to make connections with those folks, and we need to make sure that we're coming from a place of humility, and that we invite them inside of our organization and that they invite us inside of theirs. I think that when you create what I call a gracious space for learning, collaboration, and the ability to really work collegially together, it makes a difference. I think we can co-own and co-create things together, and we really, though, have to kind of initially just open ourselves up to new experiences, new opportunities in a very humble way, and ask the questions that we don't have the answers to. And I think that's probably one of the spaces where we could also be a convener of a group of folks that we really want to learn more about, that have a skill set and competencies that we don't necessarily possess now, because we can't know it all and we can't be it all. Despite what you might tell your children, you can't. It's one of those opportunities for us to be able to actually say, let's partner with people, let's convene a group together and figure a path forward for nurse leaders and their competencies to manage and lead across the continuum.
That's great, thank you. And I think we probably have time for one more. And we've had a lot of discussion, and you certainly have heard it throughout much of the debates that have been going on about the cost of healthcare and the affordability piece of that. And we've certainly have had conversations at the AHA board, the AONE board, and at our regional policy boards. So the question is, how can AONE influence the cost of pharma and healthcare technology, forcing a look at this cost and not just cutting nurses delivering care?
So I'll start with a couple of comments, and I'll say, first of all, get involved. Own it. Get involved with the pharma companies. Get involved with technology companies. Learn what they're doing. They do expert panels all the time. They pull in, and they want the chief nurse and nurse executive voice at their table. They realize that we are oftentimes the users of their products, and they need us to be able to work on that. I think the other part is really disruptive innovation, looking for things like what Mike Ebling said. How do we do this better, faster, and cheaper? And how do we partner with those folks that are the disruptive innovators inside healthcare, but also outside of healthcare as we work through that process? The conversation about can we own affordability and can we impact it, I think it's more influence and more impact as opposed to own. But we know where the waste is in the system as nurses. We know the opportunities that exist. And to your point earlier, if we don't speak up and use our voice and identify those things and learn ways to make process improvement and Lean Six Sigma and improve our skill base and our financial acumen and our business skills, and then get positioned to be able to make an impact, then we really don't deserve a seat at the table. And we really can't complain about the issues that are out there unless we're willing to get involved.
That's very true. Thank you.
I just add the innovative care models as well. I think as we really move forward and we partner with our members in our health plans, we're going to see many more innovative models that will be less costly, because we're partnering with the person who's using the scientific information that we bring to the table with that individual so that they can help manage their own health and their illness. So I just think more and more of that is going to be key, along with the different products that are produced.
Agree, and I actually had seen several poster presentations with really significant, innovative, and cost-reducing models of care. So how about we give our panel a round of applause?